Dr. Baliga here. This podcast belongs to a set of 10 podcasts on the topic of geriatrics. It's from an outstanding chapter on geriatrics in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It covers important topics including functional decline and frailty, cognitive impairment and dementia, evaluation of cognitively impaired elderly driver, depression in late life, hearing impairment, vision impairment, urinary incontinence, undernutrition, pharmacotherapeutic considerations in the elderly, including pharmacokinetics and pharmacodynamics, elder abuse and neglect, goals of care and advanced directives, and prognostication. After listening to these 10 podcasts, you should have a solid foundation in geriatrics and should help you provide better care to your senior citizen patients. This chapter is authored by Dr. Jeanette Ross, MD, who's professor at the University of Texas Health Science Center at San Antonio. She is the Associate Program Director for Geriatric Fellowship and Director of Didactic Activities for Palliative Care and Geriatric Fellows. Her academic interests include integrating geriatric palliative care content into educational programs at the undergraduate and the graduate medical educational levels. The senior author is Dr. Widera, MD, who is Professor of Clinical Medicine in the Division of Geriatrics at the University of California, San Francisco, UCSF. He is also the Associate Program Director for Geriatrics. His main goal is to improve the care provided to elderly patients with severe chronic and/or terminal conditions through program development and educational interventions. Multiple choice question. An 85-year-old male is asked by his wife to come to the office to have his hearing assessed. The wife states that over the past month, her husband has decreased hearing on the left side and she has to yell on his left ear for him to hear her. Vital signs are within normal limits. A recent chemistry and CBC were normal. When asked if he has any discharge from the ear, the patient states, "My ears are immaculate. I use cotton swabs every day to clean them." Which of the following is the next step to assess this patient's hearing loss? A. Refer to audiology for a hearing test, that is audiometry. B. MRI of the brain. C. Perform Rinne-Weber test. And D. Otoscopic examination of the auditory canal. And the answer is D. Otoscopic examination of the auditory canal. A common cause of hearing loss in older adults is cerumen impaction. A simple otoscopic examination will identify it and is the first step in evaluating hearing loss. Older adults have cerumen that is thicker and has a tendency to accumulate. The excessive use of cotton swabs in the depicted scenario can contribute to the cerumen being pushed into the auditory canal. The audiometry test measures hearing thresholds of pure tones through a frequency range of 250 to 8000 Hz. In this depicted case, it's not indicated unless the hearing deficits persist after the earwax is removed. The Rinne-Weber is a quick learning test that is used in the evaluation of unilateral ear loss to help distinguish conductive hearing loss versus sensorineural by using a vibrating tuning fork. and an MRI of the brain is not necessary at this point. Hearing loss is the third most common ailment in older adults, affecting over half of adults older than the age of 70. Failure to assess for and treating hearing loss may result in significant consequences, as it is associated with depressive symptoms, cognitive deficits, functional decline, social isolation, and a poor quality of life. Hearing loss can be classified as conductive, sensorineural, or mixed. Conductive hearing loss is caused by impaired transmission of sound from the external ear to the inner ear. The most common causes in older adults include cerumen impaction, otosclerosis, and otitis media. Sensorineural hearing loss is caused by cochlear or retrocochlear pathology due to disorders such as Meniere's disease, labyrinthitis, or drug-induced ototoxicity. Presbycusis is the most common form of hearing loss in older adults. Presbycusis is a symmetric sensorineural hearing loss that preferentially affects higher frequencies. Screening for hearing loss can include pure tone audiometry. However, whispered voice test at 2 feet or a single question regarding perceived hearing loss is nearly as effective. All patients with suspected or definite hearing loss should have a physical examination evaluating for common cause of hearing loss, including cerumen impaction, and should be referred to an audiologist. Referral to an otolaryngologist is indicated in sudden or significantly asymmetric hearing loss, presence of a perforated tympanic membrane, persistent and copious ear drainage, hearing loss associated with severe vertigo, or signs of severe infection. The Global Burden of Disease study found that hearing loss is the fourth leading cause of disability globally. In the US, the prevalence of hearing loss doubles every 10-year increase in age. Approximately half of the persons in the seventh decade, that is 60 to 69 years, and 80% who are 85 years of age or older have hearing loss that is severe enough to affect daily communication. Because of the aging population, hearing loss is likely to become an increasingly prevalent disability. Older persons with hearing loss have higher rates of hospitalizations, death, falls, and fatality, as well as higher rates of dementia and depression, even when risks for these disorders are taken into account. Despite increasing knowledge of the biology of the inner ear, hearing restoration is not currently available in most cases of hearing loss. Listeners are recommended a New England Journal of Medicine article titled Hearing Loss in Adults from December 21, 2017, authored by Dr. Lisa Cunningham, PhD, and Dr. Deborah Tucci, MD, MBA. This podcast is derived from an outstanding chapter on geriatrics in Baliga's textbook of internal medicine, available at www.mastermedfacts.com. It's authored by Dr. Jeanette Ross, MD, professor at the University of Texas Health Science Center at San Antonio. She is also the Associate Program Director for Geriatric Fellowship. Her academic interests include integrating geriatric palliative care content into educational programs at the undergraduate and graduate medical education levels. Her main interests include advanced communication skills, goals of care, pain management, and management of falls in the elderly. Her clinical activities are based in the South Texas VA healthcare system, where she is a staff physician within the Geriatrics department and extended care services, and she is affiliated with the Geriatric Research, Education and Clinical Center. She works in the Geriatrics and Palliative Care Consultation Service and the Geriatrics Clinic. Dr. Eric Widera, MD, is Professor of Clinical Medicine in the Division of Geriatrics at UCSF, that is University of California, San Francisco. He's also the Associate Program Director for Geriatrics. His main goal is to improve the care provided to elderly patients with severe chronic and/or terminal conditions through program development and educational innovations. Dr. Widera accomplishes this through various leadership roles, including Director of the Hospice and Palliative Care Service at San Francisco VA Medical Center, and he's the Program Director for the Geriatric Fellowship at UCSF. He has been the recipient of numerous grants and awards, including a Geriatric Academic Center Award at the Hastings Center Kenneth Dixon Physician Award and the Hartford Foundation as a Center of Excellence Faculty Scholar Award.